Hello, my name's Lorelei Jones. I'm a lecturer in healthcare organisation and governance at the University of Bangor, and today I'm going to be talking about relational accountability. So, this research is part of a broader evaluation of dental reform in NHS dentistry in Wales, and that's funded by the Welsh Government. So, health systems all over the world are interested in value-based healthcare. This comes from a concern that activity-based approaches to accountability and monitoring, such as fee-for-service and diagnostic-related groups, that these are incentivising the wrong thing. So they're incentivising quantity and not adequately attending to quality. There's also concerns that activity-based systems reinforce organisational silos. So they're focused on the performance of individual organisations, and really what we want to be interested in is the performance of the whole system. And we want to be encouraging organisations to work together and collaborate. So value-based healthcare can be understood as those efforts to refocus on outcomes relative to costs and on the coordination of activities between different organisations, because health services are never provided by just one organisation, they're always provided by organisations working together. So as part of our research, we talked to stakeholders at all levels in the system. So we spoke to policymakers at the national level, we spoke to regional health boards, and we spoke to dental teams, local dental teams as well. We found that stakeholders at all levels in the system wanted to move away from a system based on measuring units of dental activity to one that incentivised prevention, oral health across the practice population and the community more generally, clinical innovation, and patient-centred care. So there was a real consensus around what they wanted the objectives of healthcare governance to be. When we talked to local dental teams, we found that the goals of the Welsh Government in terms of their contract reform, that these aligned very well with the professional values, interests and beliefs about what it means to be a dentist and what it means to be providing high quality dental care. And this is important because if any policy aligns well with the professional values of those who are delivering the service on the ground, then this can really help with implementation. We found that local dental teams, dentists in particular, really wanted to move away from the current system, which left them feeling like they're on a treadmill. The other interests of local dentists were work satisfaction across the whole team, that was very important, as well as financial security. They remained concerned about the amount of paperwork that was involved in accountability and monitoring, and they often felt a bit over-monitored by health boards. Because of the focus on the previous system on measuring activity, they were concerned at appearing like a statistical outlier because they weren't meeting those expectations for activity. And so one of the consequences of this was that they did sometimes avoid clinical innovation for fear of appearing as a statistical outlier. So when we talked to dentists about what for them would be the ideal contract, there was a preference for capitation, again, rather than simply counting activity. This is a system where people are paid according to how many people they have on the list, as well as the need and risk in their patient population. They're interested in performance indicators that captured quality as well as outcomes, and they're interested in the development of care pathways. In particular, what local dentists told us was that they wanted a better relationship with the health boards. They wanted more of a dialogue about their approach to quality, about the innovation that they were doing in their practice, about their particular local circumstances and the challenges that they faced. So they wanted this ongoing conversation with health boards about quality, and we've called this here relational accountability. When we spoke to the health boards, they were also not huge fans of the activity-based system. They felt that it incentivised the wrong things. They didn't think it incentivised adequately quality. And they also welcomed a change that allowed them to be commissioners planning for the future rather than simply contract managers. However, they were concerned about regional consistency. They wanted regional consistency, and they wanted more clarity from central government on exactly what dental practices should be doing. They were concerned at their capacity to manage a lot of different contracts with practices, and they wanted benchmarks to help them to assess performance. So we're starting to see here a little bit of tension between the needs and the preferences of health boards for standardisation and the preferences of local dental teams for more flexibility and for more of a dialogue about particular circumstances. So, to conclude, we found that an element of relational accountability aligns well with professional values, especially clinical autonomy. And our research is ongoing, but what we've found so far is that trust appears to be very important. Trust between health boards and local dental practices emerged as a key mechanism for stimulating creativity, clinical innovation, engagement with policy implementation, and staff satisfaction. And this is likely to have knock on effects for quality of patient care. Thank you.